Good evening. My name is Chantel, and I will be your conference operator today. At this time, I would like to welcome everyone to the Living Well with Myeloma, Understanding the Immune System and the Lab Value in Myeloma conference call. All lines have been placed on mute to prevent any background noise. After the speaker's remarks, there will be a question and answer session. If you would like to ask a question during this time, simply press star, then the number 1 on your telephone keypad. If you would like to withdraw your question, press the pound key. Thank you. Robin Toohey, you may begin your conference.
Thank you, Chantel, and welcome, everyone. Good evening. I'm Robin Toohey, Senior Director, Support Groups of the International Myeloma Foundation. And it's my pleasure to welcome you to tonight's Living Well with Myeloma teleconference, Understanding the Immune System and Lab Values in Myeloma. Tonight's teleconference is part of the IMS Living Well with Myeloma teleconference series, which is designed to cover all the important and most up-to-date information regarding myeloma to help you live well. I'd like to thank our sponsors for their support of tonight's call, Celgene Pharmaceuticals and Millennium, the Takeda Oncology Company. If you have not yet downloaded the slides for tonight's teleconference, please go to myeloma, myeloma.org, and click on the top bullet under New and Noteworthy, and you'll be able to access the slides there. Or you can go directly to the slides online at labvalues.myeloma.org. Now I would like to introduce Ann McNeill. Ann works at the John Thayer Cancer Center at Hackensack University in New Jersey as a nurse practitioner in the Multiple Myeloma Division. Her responsibilities include direct patient care as well as disease and treatment education that is provided to patients and their caregivers. Ann is also involved in the education of new oncology nurses at the Cancer Center and also facilitates the monthly myeloma support group meeting at Hackensack. Ann is a member of the Oncology Nursing Society, the American Nurses Association, and the IMF is also proud to have Ann as a member of its Nurse Leadership Board. As Ann goes through her presentation, please just advance the slides as necessary. The slides are also downloadable and printable for your use and note-taking. Please remember that you will have the opportunity at the end of this presentation to ask questions. It's now my pleasure to turn the call over to our guest speaker, Ann McNeill. Ann?
Good evening, everyone. I'm happy to be the speaker for tonight's presentation, which is Understanding the Immune System and Laboratory Values in Multiple Myeloma. I'm going to go to the first slide, which is titled The Immune System. And for this slide, I have listed here the two subsets of the immune system. Now, the immune system is a very important part of our body. We certainly could not live without an immune system. It's integral to our survival. And our immune system is made up of two portions, you might want to call them. We have a cellular immune system, and that's composed of a variety of white blood cells. Some of them you may have heard of, granulocytes or neutrophils, and lymphocytes, specifically T cells, are involved in the cellular aspect of our immune system. And then we have the immune system section called the humoral immune system. And this section is composed of the B cells, and more specifically the plasma cells, and the resultant antibodies that are made by the plasma cells. So if we move to the next slide is a picture. You can see that there's a B cell on the left side of the slide. The B cell works chiefly by secreting antibodies, and actually the B cell further matures into a cell called the plasma cell. So if you look on the slide, you'll see the B cell on the left, and there's three larger cells sort of centrally located on the slide. Those are the plasma cells. And the plasma cells are the cells that specifically secrete these antibody molecules. These antibodies are also called immunoglobulins. So antibodies and immunoglobulins are two terms for the same thing, and that thing is a protein that is secreted by the plasma cells, and that is actually denoted on this slide by the little purple Y-looking diagrams on the slide. If we move to the next slide, it'll say AB antibody structure. AB is an abbreviation for antibody. So this is what the basic antibody structure looks like. And every antibody, and we have millions and trillions of antibodies that float around in our body normally, they are actually they serve a very important purpose in our body. They are protective mechanisms. The immune system helps to protect us against infections and invasion of foreign substances, and we do have many, many antibodies floating around in our blood, and this is the basic structure of each antibody. So the green portion is the heavy chain, and the little yellow portions that are attached to the main portions are called the light chains. So every antibody is composed of a heavy chain and a light chain, and in this molecule, they are attached by something called disulfide bonds. Those are just chemical bonds that sort of keep all the parts together. So this is the basic antibody structure. If we move to the next slide, it's entitled Types of Antibodies. So the green portion, that heavy chain that I referred to on the previous slide, there are 5 different types of heavy chains that can comprise our antibody molecules. And they are listed here. The first one is IgG. We can have IgA, IgM, IgD, and IgE. I do want to point out that most commonly for myeloma patients, the antibody that's involved is an IgG antibody, and the second most common is an IgA. IgM myelomas are exceedingly rare, as well as IgD and E myelomas are also very rare. You may or may not know which type of myeloma you have, but like I said, IgG is the most common, and then IgA is the second most common. And then we have light chains. So that little yellow portion on that previous slide, which was entitled light chains, there are 2 types, and they are given Greek alphabet names. One is kappa and one is lambda. So if we have a full intact antibody molecule, we can have an IgG kappa or an IgG lambda, and we can also have an IgA kappa or an IgA lambda, and so on. So all the antibodies have a heavy chain and a light chain, and there's all different types of antibodies that float around in our bodies. If we move to the next slide, the title says, What Happens in Multiple Myeloma? So this is going through the story of actually what happens in patients who are diagnosed with myeloma. There is a malignant plasma cell that makes a clone of itself. So a plasma cell that lives in the bone marrow, again, I didn't mention, but I should mention that the plasma cell lives in the bone marrow, and the bone marrow is a very important part of certain bones in our body. It's a central sort of spongy tissue that's in the center of some of our bones, and that's the whole warehouse of all our blood cell production. So the plasma cell lives there, but what happens in myeloma is that a plasma cell becomes malignant, and it makes a clone of itself, and it divides and accumulates in the marrow, and they pretty much stay in the marrow. But these malignant plasma cells secrete that antibody that I mentioned prior, or immunoglobulin, but the antibody is now called the M protein, or M spike, or paraprotein, or myeloma protein. So you can see that it has many, many names. And the reason it has a specific name is because this antibody produced by the malignant plasma cells is not particularly useful to the body. So it can be detected in the blood and or the urine of most of the myeloma patients, but it doesn't serve any significant purpose in the body. It doesn't help to protect the patients against anything, but it's just kind of there. It's a product of the malignant clone of plasma cells. If we move to the next slide, it says laboratory testing for multiple myeloma. So this is where I want to focus on a lot of the different lab tests that we do to help diagnose, monitor, and treat myeloma. Lab tests are very, very important. So why do we perform lab tests? And we have many, many reasons that we are looking to perform some of these specific laboratory tests. One of the goals is, of course, to help diagnose the disease. So these are extremely important to help diagnose appropriately whether or not a patient has what we consider active myeloma that requires treatment. And some of the testing that we do also helps determine the severity or the spread, or in other words, staging of the disease. That's also important. We use these blood tests frequently throughout the patient's journey with myeloma to help monitor the progress of disease. What is actually going on with the myeloma? Is the treatment that we are utilizing, is it working? Is it helping to keep the disease in control? Some of the lab tests will help us to detect complications. So some of the complications of myeloma we'll go into later, but we want to make sure that the kidneys are being protected, that they're functioning properly, and some of the other organs are functioning well. We can detect a lot of complications. And of course, like I mentioned before, we want to monitor the effectiveness of treatments that we are using to treat the myeloma. We certainly would not want to keep a patient on a treatment that is not effective, and some of these lab tests are crucial in helping us to determine whether or not the treatment is efficacious. And the next slide is entitled Comprehensive Metabolic Panel, or what is commonly known as the Basic Metabolic Panel, or the chemistry screen. And this is a very, very common group of tests. They are used to evaluate a variety of things. Some of them are your kidney and liver function, your electrolyte status, and by electrolytes I mean sodium, chloride, potassium. And we also use this chemistry screen to determine your calcium level and your total protein levels. So some of the tests that are extremely important, and this battery of tests can consist of 12, 18, 20 different single tests depending on the lab that you go to or the institution that is running the test. It's a whole battery of tests. Some of them that are important are the total protein. The total protein level is frequently elevated in patients with myeloma, and sometimes this is the only test that is abnormal when a patient gets diagnosed with what we think might be myeloma. The reason the total protein is elevated in the blood is because these antibodies that are produced by the malignant plasma cells, they are proteins. These antibodies or immunoglobulins that I talked about before, these are proteins. So if you have an excess amount of these antibodies in your blood, your total protein level will be increased. So this is an important test. The calcium level is very important. As some of you may already know, patients with multiple myeloma, we must protect the skeleton, the bones. This disease has a characteristic effect on the bones. There can be a lot of bone destruction in patients with myeloma. And bones, one of the major minerals that make up bone is calcium. So when you have bone destruction, you will leak calcium out of the bones into the bloodstream. And that's not a good thing. So if you have an elevated calcium level in your blood, that can lead to problems. So we definitely look at the total calcium level in your blood to help us determine what's going on with the disease. Again, those patients are usually symptomatic, and we have to treat that urgently. The other test listed here is creatinine. The serum creatinine levels are the best indicator of how the kidneys are functioning. So again, I did mention that the bones are somewhat vulnerable in patients with myeloma, and that is true, but also the kidneys are somewhat vulnerable to damage in patients with myeloma. So we are concerned always with how the kidneys are functioning. To determine how the kidneys are working, we look at the serum creatinine level. If the creatinine level is going up, that means that the kidneys are not functioning as well, and that is a concern for us and for the patient too. Okay? So the next slide says other chemistry tests that are important in multiple myeloma. So we can briefly go over some of these. The beta-2 microglobulin test is actually not part of the routine chemistry screen. It's a separate test that's usually ordered when we suspect someone has multiple myeloma. This is a marker that is frequently found on certain cells. Some of the cells are lymphocytes, and the plasma cell is a very specialized lymphocyte. So we do see an increase in the beta-2 microglobulin in patients with myeloma. This level can sometimes answer the question at diagnosis, how much disease is there? So it's an indirect way for us to answer the question, what's the tumor burden, how much disease is there. We use this test basically at diagnosis and really do not use it to monitor the effectiveness of treatments or anything else. We really use it in the beginning to kind of stage a patient too. This is an important test for staging, as well as the next test, which is the serum albumin level. Again, this test is normally a part of the chemistry analysis. The serum albumin level is important for the ISS staging system for myeloma. That's the international staging system. We need the beta-2 microglobulin level as well as the serum albumin level. And all I want to say about the serum albumin level is that when the level decreases, it's a concern for us because it's an indirect way of telling us that the disease is becoming more active. So we use the beta-2 microglobulin level as well as the serum albumin level, and we can put, based on those numbers, patients in a staging system, whether they be stage 1, 2, or 3. Serum viscosity is listed here. Serum viscosity is the thickness of the blood, so how viscous the blood is. If you can imagine that if you have a lot of these antibodies or immunoglobulins floating around in your blood, these are very big molecules of protein, and if you have a lot of protein, excess protein in your blood becomes more viscous or more thick, and that can lead to certain problems when the blood is more sluggish or thick. So that sometimes we do a serum viscosity level on patients with very, very high immunoglobulin levels. If we move to the next slide, the title of the slide is Complete Blood Count, or the CBC, and most everyone is familiar with the CBC. This is probably the most common blood test that is done to patients with myeloma, whether they are being monitored without treatment or with treatment. So we look at the hemoglobin and hematocrit. That will determine the extent of anemia. So we're looking at the level of the hemoglobin. If you're anemic, we do act on that. We do treat that. We look at the white blood cell counts, and we look specifically at the absolute neutrophil count, or what's called the ANC. You might hear your nurse or physician talk about the ANC count. That's the absolute neutrophil count. The neutrophils are a subset of the total white blood cell counts, and these neutrophils are very important in fighting bacterial infections. So that's why we are very interested in the ANC, because it evaluates the patient's infection risk. And then we have the last one listed here, the platelet count. And again, most of you are familiar with platelet counts. You might have heard that being thrown around in your doctor's office. But platelets are responsible for blood clotting. They are very, very important because a lot of our treatments can lower some of these blood counts, the ANC, the hemoglobin, and the platelet counts. So if you have a very low platelet count, you are more prone to bleeding. And if you are on anticoagulant therapy, if you are on blood thinners, so if you are on aspirin or Coumadin or Lovenox or many of the other blood thinner agents out there, we have to be very careful of your platelet count, because if your platelet count drops, it may make you even more prone to bleeding episodes, and that's why the platelet count becomes very important. If we move to the next slide is called Quantitative Immunoglobulins. So now we're getting into the more specific myeloma blood work. The other testing is very routine. This is part of a myeloma panel. So this is the test that measures the amounts of the different immunoglobulins in your blood. So the myeloma protein will be an IgG or IgA, and like I said, rarely an IgD or IgE. Usually the quantitative immunoglobulins will measure how much IgG, how much IgA, and how much IgM is present in a blood sample. These levels will help monitor the course of the disease. Initially, you might have a very high level of IgG if your myeloma cells are making an IgG-M protein. We are aware that we would like the IgG levels to decrease as we give you effective treatments. It's also important to be aware of the levels of the normal or the non-myeloma immunoglobulins. So, for instance, if you're an IgG myeloma, we are very aware of not only the IgG levels, but the IgA and IgM, because over time, if we get your disease under control, all of these levels start to normalize. If we move to the next slide, that's entitled Protein Electrophoresis and Immunofixation. Two terms, again, that are part of a very specific set of laboratory tests that we do in our facility. We call it the myeloma panel. It's not a very routine blood test, but more specifically done for patients who have myeloma or are suspected of having myeloma. So let's talk about the protein electrophoresis first. This is a very specialized test. What it does is it separates all the proteins in a blood or a urine sample. It actually can be done on a urine sample. It breaks them up into several groups based on the size of the proteins and the electrical charge of the proteins. So they are actually put in a gel and exposed to an electrical current, and based on how big the proteins are, they all migrate to different areas on the gel. In most patients with myeloma, there'll be a large amount of an abnormal immunoglobulin protein that appears as a very large peak in a very specific area of the graph, in the area of the graph where all the gamma globulins or immunoglobulins are migrating to. So we see this very abnormal spike, and that's called the M spike, or sometimes called the myeloma spike. So that is a very specific, and that M spike can be measured. So the laboratory will take an analysis of that graph, if you want to call it, that gel, and they'll actually quantify how much protein is in that M spike, and that is the very specific measure of that abnormal protein that the malignant plasma cells are making. The immunofixation is another very important test. So while the protein electrophoresis measures the M spike, gives us a number, how many grams of that abnormal protein are present in the blood, the immunofixation is done to identify the specific type of protein that is being produced by the malignant plasma cells. So remember I was saying that each antibody, it has a very specific heavy chain and light chain. Well, if you say, I know I'm an IgG kappa multiple myeloma, the reason you know that is because your immunofixation that was done on your blood sample showed that it was IgG and kappa that is being produced by your myeloma cells. The amount of protein produced at any given time may vary throughout the course of your disease, but the type remains the same. So if you're an IgG kappa myeloma, you will always be an IgG kappa myeloma, but the measurement of that IgG or M spike may vary over time. And the next slide is entitled Normal Serum Protein Electrophoresis Pattern. And this is a very nice picture of the protein electrophoresis that I just mentioned on the previous slide. And this is a typical normal pattern for serum protein electrophoresis. So if you look on the left side of the slide, that big spike there, that is a normal albumin spike. So this is a normal patient or a patient in remission with myeloma. The most prominent protein in our blood is albumin. So we do see that denoted there on the left-hand side. And then we have a whole bunch of other little proteins that migrate to different areas. And if you look on the extreme right-hand side, you see an area that says gamma. That's where all the immunoglobulins or antibodies migrate to. If you go to the next slide, you can see a vast difference in this slide than the previous one. This is an abnormal serum protein electrophoresis pattern. So you can see that big spike in the gamma region, and that is the M spike. Okay, this is a patient who has multiple myeloma, and you can really note that the large spike in the gamma region is indicative of a clonal protein being produced by the malignant plasma cells in the bone marrow. So this is an abnormal pattern. Okay. And the next slide is entitled Serum Free Light Chains or FreeLite Assay. Okay, again, many of you are familiar with this test. It never used to be a very common test or routinely part of the myeloma panel, but in the last 5 to 10 years has been in most big myeloma centers now a standard part of the myeloma blood work panel. This is a test that measures the amount of free light chains in the serum or the blood, okay? And to kind of explain why we're doing this, I want to explain that in normal circumstances, the plasma cells produce an excess of light chains compared to heavy chains. So this is in all of us, in normal people with non-myeloma, patients with myeloma, we do produce an excess of light chains. And a small amount of these light chains will never become incorporated into the immunoglobulin molecule, and they stay free. They just kind of float around into the blood, and they are little kappa and little lambda light chains that are just floating around into the blood. This is normal. We can have normal free light chains. But if you go to the next slide, I'm going to try to explain that in patients with myeloma, most patients with myeloma produce increased amounts of these excess light chains. So either kappa or lambda light chains, which can be measured in the blood. So if you're an IgG kappa myeloma, we can frequently see an excess of free kappa light chains in your blood. Consequently, the ratio of kappa to lambda light chains is abnormal in most patients, and it's a very sensitive indicator for this disease. We are now using this assay to help monitor progression of disease and the effectiveness of treatment. So very frequently, your physician, your oncologist, your team may order this test as part of either routinely or maybe on an every couple of month basis, we'll order the serum free light chain assay, because sometimes we can see abnormalities in this assay before we see any increases in the M spike or the quantitative immunoglobulins. In other words, again, it's a very sensitive indicator for the disease, and we can see kind of, abnormalities in this test, sometimes months before we even see an indication that there's an increase in the M spike or the M protein. If we go to the next slide is entitled Bone Marrow, Aspirate, and Biopsy. So I want to stress that every single lab test that I spoke about so far provides indirect information about the amount of tumor present. If we measure proteins that are secreted by the tumor into the blood or the urine, this is a great thing because it's very easy to collect a blood sample or a urine sample from a patient, but again, it's very important to note that these are indirect ways for us to get information about the disease. These tests do not provide the same information as looking at the tumor itself. So where is the tumor? It's in the bone marrow. The myeloma cells are usually only found inside the bone marrow, and to really get a feel of what's going on, you have to look in the bone marrow. Okay, if we go to the next slide, it also says bone marrow, aspirate, and biopsy. And I'll explain what the bone marrow, aspirate, and biopsy is, and most of you can probably tell me what it is better than I can tell you what it is. So small fragments of bone marrow cells are withdrawn from a needle, an aspirate needle, and a small core of the actual bone and marrow is often removed at the same time with a different type of needle, but from the same puncture. So we usually go into what's called the posterior iliac crest, which is kind of behind your hip. We go in that area to get the bone marrow, aspirate, and biopsy. And both of these tests are done to determine how much of the normal bone marrow is being replaced by the multiple myeloma cells. So typically, for patients who do not have myeloma, we do have plasma cells in our marrow. It's a normal thing, but we have a very small percentage of plasma cells in our marrow, less than 5% normally. Patients with myeloma can have 10, 20, 30, 40, even upwards of 90% plasma cells in their bone marrow. And these malignant plasma cells take over the marrow and affect the development of all of the blood cells. One important thing to remember is not only are we looking at the percent of plasma cells in the marrow from these tests, but we need to do specialized testing, which can provide a lot of information about the biology of the disease. So what we do are tests called cytogenetics in fish and we also do molecular studies, and you might know it as gene expression profiling, or, like I said, molecular studies. What we do is we will isolate the tumor cells. The malignant plasma cells are isolated by the pathologist, and we actually look inside the malignant plasma cells at the genes, the chromosomes, the actual genetic material, and we look for abnormalities or mutations in the malignant plasma cells. And the results of that testing can help us put patients in a risk category. Patients can be a standard risk or high risk, and I do want to stress that we treat all patients with myeloma, but knowing the risk profile can help us determine how aggressive we may have to be. Maybe it can help us determine which kinds of treatments may work better. And then we do talk about, a whole bunch of things based on the staging of the myeloma and the results of this risk profile analysis. And that is the end of the slide deck. You'll see that that was the last slide. I think that now, Robin, we can open it up to questions about any of the lab tests that I discussed, or even the bone marrow aspirate and biopsy.
Yeah, thanks, Anne. And while we're waiting for questions to come into the queue, I was thinking maybe if you touch on the importance of abnormalities. So if you have, let's say, a high or a low red, white, or platelet count, what does that actually mean to patients? What should they be wary of?
Oh, sure. So again, let's go with platelets first. If a patient has, and usually the counts are low, Robin, that we're concerned about, in these cases based on either the disease or the treatments that we're giving the patients. So a lowered platelet count can predispose the patient to a higher risk of bleeding or easy bruisability. So patients may say, I just kind of bumped my arm or leg really, briefly, and I got a big bruise. Or, a man might say, I was shaving and I just nicked myself and it took a long time for me to stop bleeding. So patients will have issues relating to blood clotting. But again, if there's things like spontaneous bruising or blood in the urine, nosebleeds, this is definitely something that you need to discuss with your healthcare team, because you might have to go into the office to have your blood counts checked. So again, any of these things that I'm talking about, if you're experiencing them or you think you might have an issue with lowered blood counts, definitely a topic to bring up with your healthcare team. Lowered white counts are very important too, because that will predispose patients to an increased risk of infection. So again, if you are at risk of having low white counts, the physician or the healthcare team might tell you to report any fevers, to report any signs or symptoms of a cold or the flu, like a cough or something like that. You should really talk to your healthcare team and decide what is going to be some of the issues that should be reported and how they want that reported to them.
Okay, so Chantel, I think we're going to open the lines up now for questions, and I just want to ask everyone on the call tonight that if you have a question and you'd like to ask Anne, please remember to keep it general in nature and specific to myeloma, so it will benefit all the listeners on this teleconference. And also, please limit your questions to one, so no two-part questions, please. Chantel, do we have any questions?
At this time, I would like to remind everyone, in order to ask a question, press star, then the number 1 on your telephone keypad. Your first question comes from the line of Lori. Your line is open.
Hi, Anne. Thank you so much for doing this today.
Hi, Lori.
Hi. I have a question concerning, you talked about calcium and creatinine. I'm going to limit, I had a two-part question. I'm going to limit to one. When you talk about bone destruction, I'm wondering if a multiple myeloma patient has suffered with a plasmacytoma before being diagnosed with MM, does that perhaps suggest they are already in danger of bone destruction, or could possibly be in more danger zone in the future?
I have to be honest with you. Patients with a diagnosis of plasmacytoma, and let me just define that for those on the call that do not know what a plasmacytoma is, that is the solid tumor that's associated with multiple myeloma. So that's a very focal accumulation of plasma cells. Frequently, these plasmacytoma do break through bone, and that's how the patient will know they have a plasmacytoma. They may have a fracture already. They may have a lot of bone pain. Those patients are at risk of bone destruction. But I have to also point out, Lori, that 85% of our myeloma patients do present with some kind of bone issues or bone disease. So there is a very large percentage of patients with myeloma that are prone to bone destruction. Unfortunately, it's a very common denominator in patients with myeloma that they suffer with a skeleton that is prone to damage. So yes, you are correct that patients with plasmacytoma may be sort of from the get-go, from the start, be more prone to bone destruction because of just the way they were diagnosed. But a lot of patients with myeloma are prone or are vulnerable to this bone damage.
Your next question comes from the line of Thomas. Your line is open.
Hi, Anne. Great presentation.
Hi, Thomas.
So you mentioned the importance of the absolute neutrophil counts, and that's something that's always confused me because I would variously get an absolute count, an automated differential, and a manual differential, but often they're not labeled as neutrophils. The way I understand it, neutrophils are composed of segmented neutrophils and bands.
Yeah, that's correct. That is correct.
So I usually get an absolute count of the segs, and so I guess that's an approximation for the neutrophil count. And then sometimes I get the automated differential, which is the same thing, and the manual differential where they actually seem to count the bands and the segs separately.
Right, right. Thomas, unfortunately,
how do I interpret all those different numbers?
Right. So that's what I was going to say. Unfortunately, there's many terms for the same thing, sort of. So a lot of you may see on your CBC the term granulocytes. So granulocytes are the cells, a subset of the white cells, and neutrophils are part of the granulocytes. And like Thomas mentioned, there are segmented neutrophils and bands. Bands are just more immature segmented neutrophils. So segmented neutrophils and bands should be counted together as part of your neutrophil count. I think it's somewhat confusing for patients, and also some of the differentials will give a percentage and then an absolute count. So again, I want to stress that you really want to look at the absolute neutrophil count. The percentage is not as critically important to us. You want to look at the absolute numbers because based on the total white count, you get a better feel for the absolute neutrophil count. So you do want to look at these segmented cells, Thomas, and the bands. You kind of put them together. The lab should be really doing that. But if you take those two together and get the count of the segs and the bands, that is your absolute neutrophil count. And again, some labs call it granulocytes or they call them polys. I mean, there's a lot of different terms for these cells, but that's what you want to look for, the segmented neutrophils and the bands together. The bands are just more immature forms of the neutrophils, and we do count them in that A&C.
Your next question comes from the line of Michelle. Your line is open.
Hi, Anne. I really appreciate all this information. I'm receiving IVIG treatments to increase my, I don't know if it was the IgG or IgA levels because of constant respiratory problems. You mentioned something about bruising from low platelet counts. So is there a treatment for platelets to increase as well to stop the bruising? I do Lovenox shots.
Right.
Bruise very badly from that.
I get that. Very, very, very good question. That is a question I get from patients all the time because one thing I forgot to mention when Robin asked her question is that we can also have a low red count or low hemoglobin, and that can make patients feel very fatigued. When you're anemic, you feel very tired. And we do have some kind of ways to treat a low white count and a low red count or hemoglobin. We can give certain injections like Neupogen, Neulasta, Procrit. APRN-C, they have some shots to help us increase those blood counts. But unfortunately, for the platelet count, there is nothing that you can eat, drink, or really be given to help increase your platelet count. The only thing that really works is a platelet transfusion. And of course, we don't transfuse every single patient with platelets because the platelets that are transfused only live for a very short time in the body. It's a very quick fix. It's not a long-term fix. So there really is no real kind of treatment for low platelet counts. We just have to be aware of them and kind of monitor patients through. The only treatment for low platelets is to give patients a platelet transfusion or get their disease under control, obviously, or maybe even stop some of the treatments that may be exacerbating the low platelet count.
Your next question comes from the line of Gregory. Your line is open.
Thank you, Anne, for your nice presentation. I just recently have seen an increasing serum kappa and a rather dramatically decreasing serum lambda. Any interpretation of that?
Okay, so the serum free light chain assay, like I said, is a very sensitive indicator of the disease. So if we are, and that's a very good question, because you don't just want to look at the serum free kappa level and the serum free lambda. You want to look at that ratio. And every FreeLite assay usually is composed of three parts: the serum free kappa, the lambda, and the ratio. So if we have a patient who is a kappa, whose myeloma cells make kappa, and we are seeing an increase in the kappa with a subsequent decrease in the lambda, that is altering the ratio, and the ratio is going to be increased. So certainly that is something that you should be discussing with your oncologist and your healthcare team, because it may be an indication that the disease is, kind of acting up. Whether or not you're on treatment, maybe there has to be some changes, or sometimes kidney function can cause also alterations in the FreeLite assay ratio, but usually the serum free kappa and the lambda are altered. So this is definitely something I would bring up with my team to say, look, I did notice that my kappa level is increased and my lambda is, it's kind of decreasing. What does this elevated ratio mean to me, particularly with my myeloma? Definitely something you should bring up with them.
Your next question comes from the line of Rick. Your line is open.
Yes, Anne. Thank you very much for the presentation. Very educational. Quick question on the use of curcumin, especially for smoldering patients. Do you have a view of that? I mean, it seems like there's a lot of anecdotal conversation on the various sites.
Right. This presentation, to get into treatments, is really, really, I could be here until breakfast time tomorrow. But curcumin is one of the agents that, there's no formal study results that I am aware of. And, of course, we are a very evidence-based institution, as most myeloma centers are. So there is a lot of anecdotal stories and some even papers out there about the anti-myeloma effects of the drug. But I have to be honest with you, even though I have heard of these stories and anecdotes, we are not recommending it or any supplement until we have evidence-based proof that there is, based on scientific studies, that there is an anti-myeloma effect of certain supplements and medications as well. So I really don't have too much to say about it, but I know it is out there, and it's being studied as an anti-myeloma therapy.
So, Anne, I'd like to just interject quickly here for a moment. So, sir, the IMF did a really complete teleconference called Complementary and Alternative Medicine. Sandra Curtin from the University of Arizona in Tucson did speak quite a bit about complementary and alternative treatments. And you can go onto the IMF website at myeloma.org and go to the Living Well teleconference replays, and you can click on that and hear the full replay, as well as view the slides for that if you're interested.
Oh, thank you, Robin. Thank you very much.
Your next question comes from the line of Nancy. Your line is open.
Yes, hi. My wife is right here. She was diagnosed about 9 months ago But she has lots of fatigue, and you mentioned the red blood cell, the hemoglobin, and the hematocrit. Well, all three of those have been low, and my question is, how low is low? For instance, her red blood cells are 3.5, and the minimum is like 4.2. Hemoglobin 11.5. Standard starts at 12, and hematocrit 33, and it starts at 37. So she's been low for some time. I'm wondering if, when you talked about Procrit or Neulasta, is there anything we should be asking our doctor about to maybe increase her non-fatigue level?
Right. That's a very good question. Fatigue, unfortunately, is the most common complaint for patients, even in remission, believe it or not. So fatigue can be related to disease, it can be related to treatment, and sometimes we just don't have an answer why people are tired. Now, I don't like to focus on any specific patient, on this call, but in general, there are patients who are anemic, and even though your wife is out of the normal range, I think this is something that you should definitely discuss with the oncologist and the team about her fatigue. But I do want to point out that fatigue can be caused by a low hemoglobin, and at 11.5, maybe she is tired from the low hemoglobin, but certainly I've seen, and most of us in the myeloma world have seen lower hemoglobins, but there are many, many other reasons why you can be tired. There can be things like dehydration, some things like lack of exercise, some things like treatment in and of itself. Some of our treatments can just make patients very, very tired. There are psychosocial reasons why people can become tired. So there's a whole plethora of reasons why people can feel fatigue. So not just the hemoglobin in and of itself can be analyzed as the cause for fatigue. So again, this is something that you should be sitting down with your team and saying, why is my wife so tired still? And her hemoglobin is 11. And actually the agents like Procrit and Aranesp, which I mentioned before, in most institutions, you have to have a significantly lower hemoglobin than 11.5 to initiate therapy with those agents. So I'm not sure that would be an option for her. But again, a talk with the doctor is warranted.
Your next question comes from the line of Susan. Your line is open.
Hi, Ann. Thank you for your wonderful presentation. I just downloaded my tests, and I haven't discussed them with the doctor, and everything seems to be normal, except the calcium seems to be on the higher standard range. And they go from 8.4 to 10.2, and I'm at 10.0. Is there any concern for that high level of calcium?
So, that's still within the normal range. Mm-hmm. And for me, if I had seen those results, I probably would not even give it a second thought. But again, I'm not seeing the whole battery of tests, mm-hmm. because we do also look at, when we look at the calcium level, the healthcare team also looks at the serum albumin level. So if that's very low, it can alter the calcium level, but if you said everything is normal, I typically, as long as it's in the normal range, I'm pretty okay with that. If there's a trend, you've always been a certain level and now it's trending upwards, again, that's something that you should definitely speak to the doctor about.
Yes.
Yeah, but I wouldn't be concerned about a 10. That's still in my normal range, and I would be okay with that. Listen, if the doctor is concerned, he might say, well, we'll repeat it in a week or 2 weeks just to kind of see where the numbers are going, but I'm okay with that.
Your next question comes from the line of James. Your line is open.
Hi, Ann. This is James. Thank you for the nice presentation. I learned a lot. My one question is, after you've had a stem cell transplant, mm-hmm. I have my tests always online as soon as they're up. Which tests should I be keeping for myself an eye on?
Okay. So, again, it's really important for you to know what type of myeloma you have. And that is going to be a discussion, again, with your doctor. Based on your labs, you might be an IgG kappa, you might be an IgA lambda, you might be just a free kappa. There are some myeloma.
I'm an IgA lambda.
So you're still going to look at all the quantitative immunoglobulin levels. You're going to keep an eye on the IgG, A, and M. You're going to look at the serum protein electrophoresis. to see if there's an M spike and what the M spike is doing. Okay, you want, what I have to stress to all of you that one set of labs is not indicative of anything. You really need to kind of keep track of all your labs. The only set of labs when it's one set is at diagnosis where it's important, but then you want to follow these labs over time. You want to look at what's happening to the immunoglobulin levels over time, what's happening to the M spike, even the free kappa lambda ratios, what's happening over time. So you do want to follow the same levels that you were following before the transplant, the IgA levels, the M spike, and those myeloma numbers. You're still following the same thing to see if there's any dramatic changes.
Your next question comes from the line of Doris. Your line is open.
Hi, thank you for the nice presentation.
Thank you.
I've been very fortunate. I was diagnosed in 2011, and within a few months, I was in remission, which I've been in ever since. The only thing that happens is my HGB goes down, and I have found in the beginning I had Procrit, and then I have this new medication, I think you mentioned Al-Anon or something.
APRN-C.
And that the last time I had a shot was in December.
Oh.
And my hemoglobin has gone up and down. The last time was over 11, which I was thrilled with. And it's gone down as far as 10.2, 10.4, and then suddenly shoots up. But it doesn't go below 10. And
that's good.
That's great. I'm very, very thrilled about that. I really never knew what kind of multiple myeloma I had. Maybe I felt I was better off not knowing in a sense. I know that my M protein is fine. All the other things are fine, and I'm seeing a Dr. Nisavitsky, who your doctor there knows very well, and I've seen him as well, and I'm very happy with these results. So I'm just wondering if there's anything I should be thinking about besides that I see him, my doctor, every 4 weeks, and I see him, he examines me, does a blood test, et cetera, and says that everything is fine. And I had the shot to get the calcium up, so the bone marrow is there, and I have sort of completed those. I take Caltrate. I'm in a very good, although I know it has nothing to do with diet really, but I exercise all the time. I'm on good vegetarian, mostly vegetarian with some fish diet.
But I am going to tell you that there are many other things that can affect the hemoglobin. So not just the myeloma, not just treatment, but it's very important to realize that the kidneys have an effect on your hemoglobin. There could be other medications that can have an effect on your hemoglobin. I mean, if you're above 10 and you're seeing your doctor on a regular basis and he's telling you not to worry, you've got his blessing, which is better than my blessing. So
I feel very, very fortunate, and he's has an excellent reputation.
So you're doing.
You may know Dr. Nisavitsky.
I definitely do know who he is. Yes. So you're doing fine.
Good.
Your next question comes from the line of Rama. Your line is open.
Hi, good evening, Anne. Thank you very much for excellent presentation.
You're
My
welcome.
husband has IgD kappa multiple myeloma, diagnosed in 2012. He went through stem cell transplant last year. He's basically in remission. Every 4 weeks his blood gets tested. His WBC, RBC, and hemoglobin are they're coming up, like 4.2, 3.4, and 11.6. But first time, last 3 months, his calcium has been going up. It was 9.6, 9.8, and yesterday we found out it is 10.1. Sorry, 10.2, and the limit is 10.1. When he has other myeloma markers like IgD, M protein, and kappa lambda ratio, they're within range. Does this high calcium, could it indicate that myeloma is coming back, or he did have a plasmacytoma at diagnosis? Does it mean that there is some bone involvement and other numbers are not reflecting it?
It's very interesting that you mentioned, I think you said your husband has an IGD as in David myeloma. So that is exceedingly rare. Right now in our institution, which is a very big institution, we're only treating about 2 patients with IGD myelomas. So some of the blood work that we do, the routine myeloma panels, are very, you really have to be very aware of the blood test results. You're looking at that IGD level, and that's not a routine part of the standard myeloma panel. Having an elevated calcium, again, when you have myeloma and you see the calcium level, creeping up, you get very nervous. You say, oh my goodness, is this the bones? But there are other reasons why your calcium level can be elevated. And this has to be a discussion with your doctor. You have to remember that your parathyroids can also, their function affects your calcium level. Medications, there are many other things that affect your calcium level. So even though we don't like to see the calcium level creeping up, we also take into consideration what I mentioned before. We look at also the serum albumin level. That's important in helping us to get what's called the corrected calcium level. So this is definitely a discussion with the doctor, especially because an IGD myeloma is not a common myeloma, and some of the blood tests are not going to pick up the IGD routinely. So very important specific tests that have to be done, and like you said, looking at other chemistry analysis. So definitely something that needs to be discussed with the healthcare team. So very important to bring that up.
So I think we will have time for one more question. It's 8 o'clock now, so I would like to stay on time. But I'd also like to remind those of you that are online looking to ask Ann a question that the IMF has an info line, and you can call the info line at 1-800-452-CURE, and that's 2873. And you can talk with Paul, Missy, or Judy anytime about any questions you have as a follow-up to this call tonight. So let's wrap up with one last question, and then we'll have a final moment.
Your next question comes from Victor. Your line is open.
Yeah, so to follow up on what you said about immunofixation, in the sense that doesn't change, right?
Right.
Your type of myeloma.
Right. The type of myeloma.
So my question is, if that test involves a cost, why bother doing that test month after month? Shouldn't that just be dropped?
Okay, so that's a very, very good question. It gets a little complicated. So here's why we do the test. Now here in our institution, we do it at diagnosis, of course. We don't do it routinely if there's an M spike, like if the patient has a stable M spike of whatever it may be. But the reason we do that test, because you're right, the result doesn't change. But why we do that test is because we may have a negative serum protein electrophoresis. So you may have a protein electrophoresis in your blood that shows a normal pattern. So you get that result back and it says normal pattern, which means your M spike from that test is 0. When you do the immunofixation and you still find the presence of that antibody, IgG kappa or IgA lambda or wherever it may be, that means that there really is a trace M spike present that we're not able to quantify. So that it becomes very important when we're trying to put people in a category regarding their remission. So in other words, a complete remission means there's no evidence of that monoclonal protein. So we must do an immunofixation, because if that is also negative, then we can say the patient's biochemically, based on their labs, in a remission. There's no evidence of the M spike. But if we have a negative protein electrophoresis, no M spike, but we still see that immunofixation is positive and there's still like a small band of an IgG kappa or whatever present, then we do know that there is an M spike present, but it's so small that we're not able to quantify it. So excellent question. It doesn't change, but it does help us to determine whether or not there's still the presence of that M spike. Okay, excellent question to end the very, very good question to end the session.
So, Anne, this really was amazing. I think everyone on the call has learned a lot, and they can go back to their doctors and ask really important questions that pertain specifically to them, because we all know everyone's myeloma is very individual, and the best thing to do is to go back to the doctors and talk to them more about your own labs and your immune system. So, Anne, thank you for taking the time this evening to help us better understand our immune systems and lab values in myeloma. And I'd just like to give a few reminders to everyone that's still on the call. The IMS does have a replay available of our teleconferences, and you could access the replay at a very easy-to-remember website. It is replay.myeloma.org. And from there, you'll see all the various teleconferences we've had in the past. Our final Living Well teleconference for 2014 is scheduled for Thursday, November 13th at 7 p.m. Eastern. The topic will be bone health and management of bone disease in myeloma. Our guest speaker will be Dr. Matthew Drake from the Mayo Clinic in Minnesota, and he's also a member of the IMS International Myeloma Working Group. So please mark your calendar for this important teleconference. Also, for those of you living in the tri-state area or traveling to New England this fall, the IMS last Patient and Family Seminar of the year will be in Short Hills, New Jersey on Friday, October 10th and Saturday, October 11th. You can go to the IMF website to register and for more details. And last but not least, I just want to remind you that the IMF is here to assist you with any questions you may have regarding myeloma. So please feel free to call the IMF info line at 1-800-452-CURE. And the phone lines are open Monday through Friday from 9 a.m. to 4 p.m. Pacific. So thanks once again to our sponsors for this evening's call. That's Celgene Pharmaceuticals and Millennium, the Takeda Oncology Company. And most importantly, thanks to all our participants on this call. We hope this presentation has helped you better understand your immune system and lab values in myeloma. And I wish you a wonderful evening. Thank you.
Good evening, everyone. Thank you.
This concludes today's conference call. You may now disconnect.